My name's Dr. Maccoll. I'm one of the bariatric surgeons at the Altru Health System, and I want to talk today about some of the operations that we offer here at the Altru Health System. The first one we're going to talk about is, as you can see on the slide, is the roux-en-y gastric bypass. And what you do there is you make a small pouch, and then you divide the small bowel and bring that small bowel up to the small pouch, and then you hook the two pieces of small bowel distally. And that's why it's called a roux-en-y. As you can see in the picture, it looks like a Y. Now that's an operation that's been done laparoscopically and open. These are some of the risks of this operation. Pulmonary emboli, blood clots from the legs going into the lungs, happen about 1 to 3% of the time. So if you do 100 operations, you'd expect 1 to 3 out of those patients to get a pulmonary emboli. You can get leaks. Most of the staple leaks are around that small pouch I showed you, but it can also happen down low at the lower anastomosis, or it can happen in the piece of stomach that's still there. Those are the two big reasons, these leaks and pulmonary emboli, why 1 out of 200 people who have this operation will die. So it's a big operation. Bleeding can cause us to have to transfuse you 1 to 3% of the time, and these other risks are meant on the screen kind of show you that this is an operation that works real well, but it's an operation that does have its significant risks. That is a lap band, and a picture says 1,000 words. You really see that we're not diverting anything, we're not cutting anything, we're just putting a band and putting it around the upper part of the stomach. And that's how it works. You can see on your picture there that there's a port over to the left, and that's pretty much where we put it. And that's how it works, that the adjustability of putting fluid into that port is what makes it work. So there's restriction, but there's other things like compression of the vagus nerves that explains why it works. Now there's risks of this procedure also. There's a thing called band slippage, where part of the stomach comes through the band. Now that's usually a trip back to the operating room. Some of that's inevitable when you have a hard band and a soft stomach, but a lot of it is because people are vomiting. So we really have to be careful about how people eat after surgery, and that's why we spend a lot of time talking to people about how to eat, when to eat, and what to eat, so that we can keep slippage to a low level. You can get erosion where the band works its way through the stomach. Pretty unlikely, 1 out of 1,000 or less. We can have port infections, we can have problems with emptying of the esophagus, but these are pretty rare, and they're usually treated pretty conservatively by either taking fluid out of the band, or if we have to, taking the band out. This is a new operation that is being offered in the United States called the sleeve gastrectomy. It's an operation that is obviously restrictive. If you look at the picture, you can see that most of the stomach, 95%, is removed. But there's more to the story. This operation causes restriction, but it also, there's a lot of metabolic things that happen, many of which we don't understand, just like roux-en-y gastric bypass and lap bands, why diverting part of the stomach or restricting things makes a difference with weight loss, but indeed it does. So this is an operation that we're going to start offering in July of 2008. And in terms of risks of this operation, it's a new operation, but we expect the same kind of risks in terms of leaks of 1 to 3%, probably less, but we got to at least say that it's going to be at around those numbers. We still expect pulmonary emboli, but we don't expect to have the metabolic things that happen when you divert somebody's intestinal stream, and there's at least 1 less anastomosis to worry about. So, any questions?